get the questions onto the speaker as well. Next, we have Dr. Agarwal, who's a pediatric hematologist from UCSF with the interest in complement-mediated TMA and all TMAs in general. So she'll talk to us about immune TTP management and also workup of these patients. Thank you.
Thank you, Satish. My case is not as exciting as Clay's, but I'll try my best. I have a couple of questions, so in case anyone wants to answer them on Poll Everywhere, this is the code. I'll hold on for a couple of seconds. Okay. We'll walk through the case. Oops, I don't know why it's coming a little down as compared to my slide. But anyway, I'll walk through the case and we'll talk about workup of thrombotic microangiopathies, discuss the diagnosis, immune TTP versus atypical HUS, because I think that's the main question, because even though their pathogenesis is so different, they have overlapping clinical features, and unfortunately, the treatment is very different. And then we'll go into the treatment. So we had a case of the 16-year-old woman who presented to the ER with 1 day of headache, malaise, just not feeling herself, pink urine. While in the ED, she had worsening headaches, 1 episode of nosebleed, which lasted about 5 minutes. Additionally, she had some sore throat and cough for a couple of days. She had non-bloody diarrhea about a week ago. No fevers, no joint pain, no fevers, no significant family history. Physical exam was notable for elevated blood pressures of 150 by 90, repeated times 2, and mild abdominal tenderness. Labs, the significant labs are shown here. Her hemoglobin was low at 8, platelet count was 30,000, creatinine was elevated at 1.8, and her serum LDH was high at 1,000. Urine analysis showed occult blood with elevated RBCs. Otherwise, her coags were normal, and because she had this worsening headaches, head CT was also obtained to rule out any bleed, and that was negative. Of course, the next thing we would get is a peripheral blood smear, and the peripheral blood smear showed some schistocytes. Just of note, schistocytes, of course, more than 1% are consistent with TMA, but sometimes right off the bat when these patients present to ED, they may not have any schistocytes on initial presentation during early phase of TTP, and that's why it's important to repeat the peripheral smear within 12 to 24 hours. So my question is, what do you want to do next for this girl who has headache, malaise, dark urine for about a day, and is found to have microangiopathic hemolytic anemia, thrombocytopenia, and AKI? Do you want to start steroids? Do you want to get eculizumab? Do you want to send Adams TS13 or continue to monitor? And I don't think there's a right answer to this. I think it's all about how you proceed, how you would proceed with this. I don't know if it's showing up. Okay, we'll just talk about this. What would you do for this patient? Yeah, that's what we did. We did send Adams TS13 and start plasma exchange. Oops. So, of course, this was a Friday evening case. This is when you get this. We do run Adams TS13 in-house, but we don't do it over the weekends. So because it was the weekend, there was no way we were getting it before Monday. So the question was, what do you want to do it right now? So in that case, we did send Adams TS13 thinking that it'll be back by Monday. But in the meantime, we did decide on plasma exchange. So of course, TMA, which is the broad variety of microangiopathic hemolytic anemia, thrombocytopenia, and AKI, it includes 3 main things: TTP, congenital TTP, and immune-mediated TTP, atypical HUS, which is also now known as complement-mediated TMA, and then secondary TMA, which is really in the setting of additional comorbidities like cancer, drugs, recent transplant, and so on. And again, the main thing that we need to differentiate, which is most time critical, is whether it is immune-mediated TTP versus atypical HUS, because their treatment is very different, and in the absence of appropriate treatment, TTP can be rapidly fatal, and atypical HUS can result in irreversible renal injury. So of course, for all these patients, we do send the labs for just figuring out what's the degree of microangiopathic hemolytic anemia, thrombocytopenia. We do want to check coags to rule out DIC and to identify end organ injury. We do send cardiac labs, liver labs, and of course, Adams TS13 activity and inhibitor assay to rule out or confirm TTP. And in cases where we do have additional history, we do want to rule out any other significant conditions like cancer, or if they were on any particular drug, if there was any history of recent transplant, if there was bloody diarrhea in this patient, we would have also sent Shiga toxin, but this patient had not bloody diarrhea. In 16-year-old patients, or most of these adolescents who do present with immune TTP, we do worry about autoimmune history, which could be the trigger for the immune TTP. So do want to send autoimmune screening and infectious workup in case there is any significant history, and renal biopsy if there is really nothing else in the history, but there is concern for TMA. So of course, as we discussed, the most time-sensitive question is whether you do want to start plasma exchange if it is immune TTP, or if it is atypical HUS, if you want to avoid plasma exchange and rather start complement inhibition, just because in that case, you would avoid putting in a central line if a patient doesn't need it. And in general, studies have shown if you start complement inhibition early on in these patients with atypical HUS, that can overall result in lower need for dialysis, lesser hospitalization, improved renal function, and lower costs. I won't go into pathophysiology of Adams TS13 and TTP, but we kind of know where it's essentially in the setting of presence of any autoantibodies to Adams TS13, which results in formation of these ultra-large 1 Willebrand factor, which then results in platelet aggregation, microvascular thrombosis, and endothelial injury, which is in contrast to atypical HUS, where there is more of alternate complement pathway dysregulation, which in turn results in platelet overactivation, inflammation, and ultimately microvascular thrombosis and endothelial injury. As we mentioned, majority of these clinical features are kind of same in immune TTP and atypical HUS, and I think that's where the diagnostic challenge remains. But there can be some clues within this range which can kind of point us to in one direction or the other. So thrombocytopenia and macroangiopathic hemolytic anemia, that is more severe in immune TTP compared to atypical HUS, which is in contrast to renal injury, which is more severe usually in atypical HUS. So if you have platelets above 30,000 and severe renal injury or elevated creatinine, think more towards atypical HUS. Malignant hypertension, it's actually more commonly seen in adults, but malignant hypertension, again, is a red flag for atypical HUS, which is in contrast to immune TTP. There was a study done recently on malignant hypertension, and I think about 50% of those patients actually had some genetic defect in their complement pathway. So many of these patients do respond to complement inhibition, even though they may not have a diagnosis of atypical HUS right off the bat. And lastly, of course, Adams TS13, less than 10% is diagnostic of immune TTP, but as we know, it is challenging to get it within a day. This, I think, mostly we have talked about. Of course, in many of these, the best thing to do in TMA is, of course, to identify, send Adams TS13 and ultimately see if that is less than 10%. But majority of the institutions, we are not able to get that. In contrast to TCH, where I think you can get it within a couple of hours. So in those cases, I think we do depend on other clinical features or risk prediction source that can guide us one way or the other. So in that cases, of course, we do start empiric plasmapheresis in majority of these cases and use clinical prediction tools. These are the most commonly used clinical prediction tools, French TTP score and Plasmic score. The French TTP score, of course, gives less. 0 means you don't have iTTP, or if it is more than 1, then these patients can have immune TTP. So I think it helps to rule out immune TTP, but it doesn't really help to know if this patient really has immune TTP or not. So majority of times we do use Plasmic score, which includes many more variables. So if you have a score less than 5, then there is very low suspicion for immune TTP. 5 to 6, indeterminate, and above 6 is classic for immune TTP. In those cases, you should absolutely start plasmapheresis. Of course, these two scores, again, are mainly for adults. For pediatrics, they have not been validated. And the reason being, as you can see, creatinine goals here, it's above 2. In majority of pediatric patients, creatinine per se is less than 2. So I think we do have to keep this in mind and, hopefully consider bringing up another prediction score, which is more relevant for pediatric population. I know at Texas Children's, there was a kid plasmic score that was created, but again, it has not been validated at a larger scale. So that's something that we can consider in the future. And again, these scores are helpful in case of new diagnosis of immune TTP. In many of these patients who have relapsed immune TTP, these scores will not be helpful because majority of these patients already kind of are familiar with their symptoms. So they can predict a relapse much faster than getting an Adams-TS score or a French prediction score. What kind of testing do you guys usually send for Adams-TS13? Do you send activity, antigen, both, rely on one over versus the other?
We send in to Mayo on university. It's both upfront assay, so they measure activity, and then there's flex component. It's less than 30% activity, then they automatically get that inhibitor assay, and then you can ask for antibodies. I think antigen is not part of testing either way or this research-based testing is lab, you certainly do antigen assays for antibodies.
Got it. I think that makes sense. Activity is much more relevant and much more sensitive as compared to antigen. Sometimes antigen can be normal in the presence of non-neutralizing antibodies or inhibitory antibodies. So activity is something that we mostly rely on. And Adams-13 inhibitor assay and antibodies can be helpful, but one thing that would be most diagnostic would be Adams-TS activity. In this patient, we did try to calculate the plasmic score. And of course, there can be times when patient falls under the low risk, then great, you don't have to give plasmapheresis. But I think, again, the challenge comes when the patient has intermediate risk TTP. And in that case, do you really wait for the Adams-TS to come back, or do you start plasmapheresis right away? And this was the score of our patient. I think her score was like 6. If the Adams-13 comes back, great. And in that case, you can depend on Adams-13 whenever it comes back. When it is less than 10%, of course, it's diagnostic for TTP, and then you can start or continue with the management for immune TTP. If it's above 20%, then it's clearly not TTP, and we should think about other alternate diagnosis. Could be secondary TMA, could be atypical HUS, and so on. If it is, again, in the intermediate range of 10 to 20%, I think in majority of the cases, people usually do continue with plasmapheresis and see how patients respond, and then decide if this patient is responding, then continue with the treatment. If not responding, then think of alternate diagnosis. The reason being, I think there was one study that looked at all these patients who had this intermediate Adams-TS13 levels between 10 to 20%, and they did find about, I think, 5 of the 20 patients truly had immune TTP. So it makes sense to continue plasmapheresis in those cases and see how these patients respond. The backbone of treatment for acute ITP historically has been a plasma exchange and immune suppression. Plasma exchange to remove the antibodies and to give them Adams-TS13, and immune suppression to get rid of any or reduce the antibodies that are circulating already. But I think caplacizumab, which somehow all my titles have disappeared. Caplacizumab is a new medication that has been approved for immune TTP as of 2019. So caplacizumab is nano antibody to VWF, and that helps in immune TTP treatment in the sense that it helps in faster resolution of TTP, of thrombocytopenia. It prevents exacerbations of immune TTP. But of course, the one side effect that always we have to worry about is bleeding, because it's a nano antibody to VWF. It can produce like VWF kind of picture, resulting in bleeding. Notably, I think in majority of the pediatric patients, we have not really seen any bleeding symptoms. The original study that was done I think majority of the patients who had bleeding symptoms were mucocutaneous bleeding and majority in adults. There were 4 pediatric patients and none of these pediatric patients actually had any bleeding episodes. So for this patient, who we know now has presumed immune TTP, we have started plasmapheresis at this point, would you consider adding caplacizumab while we don't have Adams TS13, we are just waiting for it? Let's say if you're not getting the results by Monday, it was taking a week to come back. Good point. True. True.
Yeah, if it was like an indeterminate intermediate case, I would have a hard time giving caplacizumab without knowing for sure that it wasn't just CGT, especially with the potential bleeding complications.
Do you rely on the plasmic scores for pediatric patients?
With a grain of salt. So kind of, I mean, in older adolescents, which is when that immune TTP is present. Yeah, I think they're helpful. I don't know that I used or that we used it as like confirmatory, you know.
Yeah, that's what we ended up doing. I think, again, we all worry about the insurance approval or not. So we decided to start only once we had the Adams TS13 levels. So yeah, caplacizumab studies, we've already talked about, how they help, and these were the study results. And now the backbone includes caplacizumab. And International Society of Thrombosis and Hemostasis, their guidelines for immune TTP says that you should start caplacizumab as soon as you're worried about immune TTP for any patient without waiting for Adams 13 levels to come back, just because that results in faster resolution of thrombocytopenia, greater improvement, lesser need for plasmapheresis, so lesser requirement of a central venous line in that patient. But at the current cost, it's considered not cost effective in the United States. The current cost, I think, is around $270,000 per dose, versus in UK, it is considered cost effective for a drug which is improved only for TTP and for something which is so rapidly fatal and morbid. So I think for that reasons, we decided to wait until we get back the Adams TS13 levels, just because we were not sure if the insurance is going to approve, if our pharmacy is going to approve and give us caplacizumab. And of course, we do take into consideration any kind of bleeding episodes. For this patient, she did not have any bleeding history. Her head ultrasound was negative for any intracranial bleed. If she did have some bleeding events or some kind of bleeding history, I think we would have probably thought more about adding caplacizumab or not. So finally, these were the results. Her activity was less than 2.5 and inhibitors were more than 10%, so clearly in alignment with immune TTP. So at this point, we did decide to continue plasmapheresis. We added caplacizumab and rituximab, and that actually resulted in quick recovery of platelet counts. I think once we added caplacizumab, she was off plasmapheresis within 2 days, and she was discharged within 3 days home. And then we continued caplacizumab and rituximab outpatient. And that's all I have.
So, what are your thoughts on starting rituximab early in these patients? Or do you have reservations of starting rituximab prior to obtaining the anesthesia?
Will you repeat the question?
Sure. Sadish is asking if what are the thoughts on adding rituximab early on without waiting for the inhibitor assay to come back? I think good question, but I think given the side effects of rituximab, I think I would hesitate starting it before we have the inhibitor assay come back, even though I think maybe majority of these adolescent patients, we know if it is TTP, it's probably immune TTP, and they do have autoantibodies. But yeah, I would hesitate adding rituximab before we have the inhibitor assay back. I don't know what other thing.
Our practice is to start early, because I think based on the data from UK and also ICD guidelines, is to start rituximab early on this with real concerns. So two diagnoses of immune TTP.
60% of our patients had lupus or the underlying
Right.
diseases. So starting rituximab early actually seems to help. Because it takes about 7 to 10 days to see a response for the reduction plasma exchange or for the rituximab to actually have. But at the same time, again, depends on how long it take to get activity levels back. But again, this is not a right long answer. I'm just asking about is there benefit of starting rituximab early along plasma exchange and steroids?
How about caplacizumab? When do you guys usually start that?
So, good question. I think the practice has changed, I should say, from when rituximab was approved to seems to be more comfortable and used in a lot more patients. Our pharmacy is willing to offer it prior to obtaining outpatient approval
Nice.
on the premise that there is data strongly supporting the use of caplacizumab early in these patients for better recovery and probably pass the time to come off the plasma exchange. Right, it's ongoing discussion, but at the same time, I think I would recommend that Sanofi being extremely supportive of its use. If there's a difficulty in obtaining insurance approval, that actually helps significantly in providing caplacizumab and compassionate use for several patients across the US, which is actually something that if a patient will reach out to me and to other people at CM-TMA, to Sanofi, and I think it can potentially help provide this early on to some of these patients.
And I think the last question that some people, I feel like if you talk to my mentor, Dr. Cartland, he'll probably say start caplacizumab as soon as you think it's immune TTP. Do not give plasmapheresis. And I don't know if anyone has tried that or is in favor of doing that.
That's a great question. We haven't done that for acute TTP. For relapse, then we have considered because we already know the diagnosis. Potentially, then we can do our patient management. But I think since some of our patients do have other autoimmune disease, the big question is, the plasma exchange is probably helping them or not. We're going to sort this antibodies prevention. So I think since we don't have any great data to support it yet, hopefully in the next few years, once we have the Bonari and other studies help us understand the utility of caplacizumab alone, we may need practice to change. But at this point, I think I'll be in favor of using plasma exchange upfront with caplacizumab.
Thanks, sir.
At the institution, how long would it take to get the plasma exchange interaction?
Good question. I'm new to UC. The question is, how long does it take for plasmapheresis really to start from the time that you decide you want to do it? So I'm new to UCSF, but I can say in so far, I think we had one case of TTP, and I think it depends on the time of the day, but usually nephrology is pretty quick about it. And within a couple of hours, I think we are usually able to start it. I think the issue is sometimes